Okay, hello everyone. Thank you for joining us today in this morning session. My name is Konstantin Arbiev. I am from Duke University and I am a chair of this session today. So we have six, I believe, speakers today. Let me just make an announcement. So each speaker has 30 minutes for their talks. You can spend it like the whole 30 minutes talking or just leave some time for discussion or questions. But please do not use more time than allotted. So because we have some speakers who requested a specific time slot because they do have some really tight schedule. We also have some time checker. If you notice on the top of your screen among the list of participants, if you don't see it, please scroll, you will be able to see it soon or later. It will show you your remaining time, so please pay attention to this. All right, so our first speaker today is Professor Murali Doraiswamy from Duke University Medical Center, and he will talk about COVID-19 and dementia, bidirectional risk and disparities. Murali, please go ahead.
Thank you so much. Good morning, everyone. I want to thank the organizers for inviting me. Respected Chair, Konstantin, and ladies and gentlemen. So let me share my screen. I hope everybody can see my screen. So this is my title of my talk. These are my disclosures. I have received grants and or served as an advisor to a number of companies. And I also have other financial relationships. So I think everybody knows these statistics. I've taken this from the CDC data tracker and it's current as of yesterday. There have been 28 million or so COVID-19 cases in the United States and 523,000 deaths. And everybody also knows that the impact has been somewhat disproportional with regards to different racial subgroups and different socioeconomic subgroups. So clearly you can see from the CDC data that American Indians and Hispanic or Latino people have borne the brunt of the COVID-19 hospitalization and death, and African Americans as well have a disproportionately higher rate. So one of the first questions that this slide raised to me is how has this translated into the way that COVID-19 may have impacted people with dementia or people at risk for dementia? The CDC website does not have any specific statistics on how COVID-19 has impacted dementia, though there are some statistics on how it has impacted long-term care settings. So there are three specific objectives for my talk. I may not be able to cover all of them depending on time. The first is what are the COVID-19 infection and fatality rates in dementia? Are people with dementia at higher risk for getting COVID-19 and dying from COVID-19? The second are what are the direct effects of the virus on the brain? And the third are what are the indirect effects of pandemic mitigation in the care of dementia? So one of the first studies to address this particular topic came from Case Western Reserve. This was a paper published in Alzheimer's and Dementia. They did an analysis using real-world data from the IBM Explorers platform. The analysis was done from February to August 2020. So the pandemic had just started. There was about 6 months of data. And you can see there, they had 15,000 or so people who had COVID-19 in that data set, and about 810 people who had both dementia and COVID-19. So if you look at the slide on the bottom, on the left-hand side, that shows the odds of COVID-19 infection in people with dementia. And you can see, regardless of the diagnosis, people with different types of dementia have an elevated odds ratio for COVID-19 infection, with the highest risk, in people with vascular dementia. And that's kind of interesting because vascular dementia patients may have many of the risk factors, vascular risk factors, comorbidities, et cetera, that could also put them at higher risk for catching COVID-19. If you look at the slide on the right-hand side, it shows the mortality risk, and it compares the mortality risk in African Americans versus Caucasians. African Americans are shown in the blue bars and Caucasians are shown in the orange bars. And you can see there's a number of different comparisons. The extreme right columns are in AD patients without COVID-19. What is the baseline mortality rate in someone with Alzheimer's disease? Then you have what is the baseline mortality rate in someone who just has COVID-19 but does not have dementia. And the two columns on the left show what happens if you have dementia. And you can see there's an additive effect. If you have baseline dementia, the mortality rate is much higher, maybe 2 to 3 times higher. There also appears to be a trend towards a higher mortality risk in African Americans, but it was not significant in this sample because of the relatively small numbers of people who were African American. So this was one of the first studies. The second study to look at this issue came out from the UK Biobank. As everybody knows here, the UK Biobank has roughly about 500,000 people who are middle-aged, who were recruited, and their medical records have been linked to their various types of biomarker and other data. So here's the key findings. So what they found was that African Americans had a 2 to 3-fold higher risk of developing severe COVID-19. And then they looked at the impact of a variety of comorbidities, which are shown at the bottom of this graph under the rows titled prevalent disease. And you can see out of the 10 or so comorbidities they looked at, the impact of pre-existing dementia was the highest risk factor. So people with pre-existing dementia had a 3-fold higher risk for developing severe COVID-19. So again, this is UK data. So we wanted to see, what was the impact in the United States. So to do that, I'm going to share with you some data that is not published that we generated in collaboration with a company called TriNetX. Many of you may know about TriNetX. It's perhaps the most robust real-world data set in the United States available for research. And within that TriNetX data set, they have something called the COVID-19 Research Network. So we looked at the COVID-19 Research Network data set, and I really want to thank Sierra Luciano and John Esposito, who were extremely helpful in working with me to generate this data set. So the TriNetX Dementia Research Network, you can see there are 75.4 million patients. There are 60 healthcare organizations that contribute data. So this is basically electronic health records. And it's a research anonymized data set to allow healthcare researchers to analyze this cohort. And you can see it covers the entire geographic breadth of the United States, and it's very well represented throughout academic medical centers, specialty hospitals, et cetera, et cetera. So for this particular analysis, we looked at 2 groups of patients. We looked at dementia patients who were over the age of 65, in whom a dementia diagnosis had been made since January 2020. So these could have had prior dementia diagnosis as well, but we wanted to make sure that their dementia diagnosis was current. There were 152,000 or so patients who met that particular criteria, and you can see their geographic distribution, obviously very heavily concentrated in the southeast of the United States and the stroke belt, but very well represented across the country. We also looked at a second data set, which is people with COVID-19. And you can see there were roughly about 840,000 people in this particular data set who had been diagnosed with COVID-19. And we used a variety of codes and lab test results to come up with this. It's very interesting. The distribution of COVID-19 is almost identical to the distribution of dementia patients. Again, making this analysis very pertinent. The Southeast and the stroke belt are very heavily concentrated, and these are also some of the more populated areas in the United States. So if you look at the demographics of patients with dementia, these are seniors with dementia recorded after the age of January 2020. You can see obviously the average age is about 80 or so. These are older people, about 60% women. You can see about 4% are Latino. and about 11% are African American. So fairly typical distribution of senile dementia. If you look at the demographics of patients with COVID-19, obviously it skews a little younger. The average age is about 45, about 54% female. And you can see there's slightly higher proportion of Blacks and Latinos, about 13% are African American and about 15% are Latinos. We don't have enough American Indians in this data set, unfortunately, because that's a group that almost no one studies, that I hope that the NIH and others really prioritize because they're bearing the brunt. So one of the first analysis we did was something very simple. This was, what is the risk of developing COVID-19 in seniors with and without dementia? So we constructed two propensity matched cohorts, which were matched one-to-one on age, sex, race, and ethnicity. So it was a very simple matching. You could go, multiple ways of matching. You could match on medical comorbidities, you could match on socioeconomic disparities, et cetera, et cetera. But for the sake of this presentation, we did a very simple matching, and we resulted in two identical sample size cohorts of 150,000 people each. The purple shows people who have dementia, and the green shows people who don't have dementia. And you can see that the odds ratio for developing COVID-19 is roughly about 2.5 times higher in people with dementia than in people without dementia. So the next analysis we did were there racial disparities within this particular risk? In other words, do African Americans have a different risk than white patients for developing COVID-19 in the background of dementia setting? So again, we constructed two matched cohorts that were matched on age, sex, and you can see that there were roughly about 16,500 people in each of these cohorts. The purple line shows white patients with dementia. The green shows African American patients with dementia. And we found that African American patients had a statistically significantly higher risk for developing COVID-19. It was not a huge increase in risk. The risk difference was about 1.2%, but still it was statistically significant. And there are some nuances here. If we had corrected for geographic region, if we had corrected for socioeconomic disparities, it's possible that the risk differences may have been different, but this is just a first cut to illustrate the kinds of data that could be generated. So the next analysis was, what is the mortality amongst people with and without dementia? And we're looking here at all-cause mortality once you've been diagnosed with COVID-19. And again, we constructed some propensity matched cohorts, which were again matched on the same variables. We had two cohorts, again here, 14,800 patients each. The purple shows people with COVID-19 and dementia. The green shows people who have COVID-19 but no dementia. And the Kaplan-Meier survival curve shows their all-cause mortality in the last 1 year or so since COVID-19 pandemic began. And you can see here again, the risk difference is about 5.4%. So patients who have dementia have a much higher mortality risk than patients who don't have dementia. The odds ratio is about 1.7 and statistically significant. And there's a lot of other kinds of adjustments and nuances that can be done. You could ask, what would happen if we adjusted for comorbidities? You could ask, what would happen if we adjusted for hospitalization? What would happen if we adjusted for all kinds of other variables? But that's something that could be done. I suspect this is a real finding, and it confirms the findings that have been generated in other data sets. So there are two other areas that I mentioned that I would discuss. So one is, what are the direct effects of COVID-19 on the brain? So this particular slide does not show real world data, but it shows two pilot experimental studies. On the left side, it shows some studies that are emerging looking at blood-based biomarkers of dementia and what happens to these blood-based biomarkers once you develop COVID-19. And what they're showing is that 1 to 4 weeks after a COVID-19 infection, many markers of neurodegeneration and glial injury actually are abnormal. So this is very interesting and could provide a surrogate marker to track the impact on the brain. On the right side, you're showing what happens to the brain 90 days after COVID-19 infection. These are researchers that use two types of MRI scans, volumetric MRI and diffusion tensor MRI, and they're showing that 90 days after infection, there are some structural and volumetric changes, and some of these changes actually correlate with some of the persistent residual neurological and psychiatric symptoms. So again, suggesting that this is a potential bidirectional impact of COVID-19 on the brain. So is this real, and what are the long-term outcomes? Again, TriNetX provides an outstanding data set to look at it, probably the only data set that I know of in the US that can really look at this in a very large scale way. And of course, EHR data has limitations, but within that context, this provides a big sort of scale snapshot. So this is a study that's by Max Teckett, a brilliant psychiatrist from Harvard, who's now in the UK, again, working in conjunction with a group in the UK at Oxford. This is a paper that's under review, looking at 236,000 survivors of COVID-19 to see what are the neurological outcomes. And as you can see on the graph on the left, when you compare COVID-19 survivors versus survivors of other respiratory tract infections, you can see that there's a marked increase in the risk for dementia diagnoses after recovery. And this is true regardless of whether people were hospitalized, whether they developed COVID encephalopathy, or whether they even just had relatively milder outpatient types of COVID symptoms. So this is something, another area that health disparities researchers need to look at more closely to see how is this impacting different races. We don't yet know the answer to that, but this is going to be a very important question that I'm sure the NIH and others will be pursuing, and hopefully the Duke group will pursue. So in summary, I think I've tried to touch upon the emerging bidirectional impacts between COVID-19 and dementia. So dementia is a unique risk factor, not just age-related, but it goes beyond age for COVID-19 mortality and infection. And in reverse, COVID-19 appears to be a risk factor for new onset MCI and dementia. So I have not touched upon one aspect, which is what is the impact of mitigation and lockdown measures on dementia care services, which have been severely disrupted. And there are many studies showing that neuropsychiatric symptoms have worsened and potentially antipsychotic use may have increased. So that's another area that's going to be very important. And I think the striking point that's emerging is that COVID-19 may amplify inherent inequalities in dementia, especially the interaction with social determinants of health. So that's going to be a very crucial area for further research. Clearly, EHR data, as I mentioned, is not perfect. It has limitations. So there needs to be additional confirmatory research. So I want to thank you for listening, and I want to thank you for inviting me.
Thank you, Dr. Doraiswamy, for very interesting and informative talk about those bidirectional links between dementia and COVID-19. It's a really striking discovery, I believe. Let me see if we have some questions from the audience. Doesn't seem like we have it yet. Okay, let me ask the panelists then. So if you have some questions, please pick up.
Murali, thank you very much. It's a very interesting talk. My question is whether somebody tried to look at changes in gene expression for people who survived COVID and then developed dementia.
It would be an absolutely fascinating study. And you know that Duke played a pivotal role in establishing the links between ApoE4 genotype and dementia. So it turns out that ApoE4 may also be involved in the risk for severe COVID-19 hospitalization and outcomes. So I think it would be, first of all, at a very easy level to look at what is the interaction between COVID-19, ApoE4, and neurological outcomes. And then at a deeper level, we should look at gene expression and many of the things that you're capable of doing. I'm not aware of anyone that has done that, but there are many, many potential genes of interest that kind of are linked between COVID-19 and Alzheimer's, for example.
Okay, thanks. And one more question on this line. In the traditional analysis of integrated stress response genes, one kinase which phosphorylates eukaryotic translation initiation factor deals with viral infection specifically. So this kind of genes are detected in many experimental studies. And what is about COVID? Does this stress response pathway, cellular stress response pathway, is involved in such kind of defense as well?
Well, I'm sure they are. And, you know, it's kind of interesting because, you know, I come from India and I just wrote an article that you can see in the NEJM Catalyst, where we showed there's a marked difference between India and the US, for example, in terms of both COVID infection rates and mortality rates. So you could ask the question, are stress genes responsible for why COVID-19 has a very high mortality in some countries, but less so in other countries, or in some groups versus other groups? So absolutely, it'd be very useful to study those categories of genes as well. It's just that I'm not an expert in that area, so I haven't looked deeply in the literature in terms of those findings.
Is it also known what kind of inflammatory effects different kinds of vaccination have? Because concerning Alzheimer's disease and other dementia, neuroinflammation plays a huge role in this. So whether any kind of vaccination affects this issue?
Yes, it's going to be very important to track the use of, well, not only inflammatory markers, which we obviously know are linked to Alzheimer's and all kinds of infections. It's going to be important to track the use of anti-inflammatory medications, vaccines. Many data sets are not carefully capturing which vaccines people are getting and when they are getting. So that's going to be one confound in a lot of the big Alzheimer's studies that are going on, because all of the, and likewise, all of the Alzheimer's studies that are longitudinal, 80%, 90% of those patients are going to get vaccinated, and they're going to get vaccinated at different time points. So how is the impact of vaccination affecting blood biomarker collection in those studies and the results of blood biomarkers? No one has really thought about it systematically. Or if they have, I'm not aware of it. I'm sure people have, and I didn't mean to say it that way, but it's going to confound a lot of the biomarker data.
Exactly, yeah, thank you.
Thank you, Anatoly. And I forgot to mention that each panelist can also raise hand in Zoom, as you know, right? So, and I see Igor Akushevich raised his hand. So Igor, go ahead.
Thank you, Konstantin. Murali, thank you for presentation. Very interesting. My question is about changes in dementia disparities with time. Let's assume we measure disparities in 2019 without any COVID. We know prevalence, we know mortality, we know difference between, say, black and white subpopulation. What happened with this measure in 2020 after COVID in measures of dementia?
We have not looked at that, but it would be very possible to look at it in the TriNetX database, because we can look at new onset dementia diagnosis in 2019 versus 2020, for example. We have not done that analysis.
Yeah, but let's think what should we expect, yeah? Because we have higher mortality from black subpopulation, yeah? Probably if we measure pure dementia trends and disparity, we will have higher disparity in dementia outcomes, right?
No, we do. We found that the risk for COVID-19 infection and the risk for COVID-19 mortality is higher in blacks than it is in whites in our analysis. But you're asking the reverse question, which is, what is the risk for new onset dementia diagnosis after COVID-19? Is that the question you're asking?
Yes, this is a part, yeah.
We don't have that data. It would be very interesting to find that out in the data set. I don't have the answer to that question right now, but it should be very easy to find that out. I suspect that if African Americans are more vulnerable to having severe COVID-19 and are more vulnerable to having hospitalization and encephalopathy, then you would expect the rates of dementia to be higher and neurological complications to be higher in that population, but we don't know that for a fact yet.
Yeah, we don't know, but look, do we expect that COVID as an infection will be a risk factor of dementia, or maybe treatment of COVID could be a risk factor or not?
I think so. I think the data that I presented today shows it is already a risk factor for dementia. It's not 100% certain. We know that many types of infections can cause dementia. The more nuanced question is it a risk factor for Alzheimer's disease, or is it more a risk factor for some type of thromboembolic vascular dementia? That's the question that we don't know for sure, but I suspect that 100% that it's going to be a risk factor for mild cognitive impairment and dementia, because about 20 to 30% of long COVID survivors are complaining of cognitive problems. So I suspect it is. We don't have all of the long-term data yet to confirm it. And by the way, I think I saw Dr. Harvey Cohen post a question in the chat saying he wants to ask a question, but he's not sure how to. Is there a way to enable his microphone to allow him to ask a question?
Yes, sure. He can ask questions. Just unmute himself and ask questions. That's it.
Actually, thanks, Murali. I actually didn't have a question right now, but yesterday I was trying to enter something in the Q&A and there's no way to type anything in there. So I was just wondering, in case something came up, how would I do it? I guess I could do it in the chat or just chime in. That was a great presentation. I also had the same question actually that either Konstantin or Igor, I don't remember who asked it, about new diagnosis dementia post COVID, but that's information to come, it sounds like.
I think so. I think so. You know, all of the information points in the right direction. We now have blood-based biomarkers, so we can longitudinally track COVID-19 patients after recovery to see what is the trajectory of these markers, because they may predict future dementia, you know, but way before we have 10-year follow-up data.
Yeah, it'd be interesting to follow.
Yeah.
Okay, any other questions from the panelists?
Yeah, I'm sorry, I probably, maybe I missed something at the beginning. I joined a bit later, but my question about sex differences, because we all know that for Alzheimer's disease, there is, for females, we observe higher risks than for males. What about in this regard for when we consider also COVID-19?
Yep, great question. I did not look at sex differences yet in this data set. And I have not seen any of the other studies report sex differences as well. Mm-hmm. But it's going to be very important to look at it. So we don't have a good answer.
So there should be no like one-to-one, well, very close link between Alzheimer's disease and COVID-19.
Correct. Correct. Yeah, we have not looked at that yet, so.
Okay, thank you.
Okay, thank you, Alexander. Any other questions?
I'm happy to give up some time for the next speaker if you want, if we have no other questions.
Actually, I have some small questions, technical. On your slide 14, when you showed direct effects of COVID-19 on the brain, what were the age ranges for those patients? Do you know it?
Yes, those were just normal young patients, middle-aged patients. They were
middle-aged
patients.
So it's not like elderly. It's just so it happens. Yeah. Effect of COVID-19 happens at middle age also. Oh, yes. That's scary.
Yeah, okay. Because people can get all kinds of neurological complications from COVID-19. There's now evidence the virus can enter the brain directly. There is evidence of changes in the blood-brain barrier permeability. They could also be indirect effects through various neurotransmitters and chemokines and so on and so forth. So yes, it happens at all ages.
Okay. Do you know if it happens also for other coronaviruses or just this one?
We know it happens for other viruses for sure. You know, we know not only just viruses, all kinds of other infectious agents. So we've known syphilis can cause dementia for years. We know HIV, you know, related cognitive impairment. And there's increasing evidence that even Alzheimer's may be linked to a variety of gut-brain links. So the short answer is yes.
Thank you. Okay, it's very interesting knowledge. I didn't know it. Okay, all right.
You're welcome.
So if no,
I just want to thank the chair and the organizers again. Thank you so much.
Thank you, Dr. Doraiswamy. Thank you for very interesting talk.